Welcome everybody to the inaugural iteration of the reformatted Schulich Heart Center Grand Rounds, and it's fitting that the speaker for the very first session is Dennis Coe, who's also now the organizer for these Grand Rounds and has steered this reformatting and lining up new speakers. And it is very fitting that he's lined up himself as the first speaker because Dennis is superbly qualified to talk about outcome research and interventional cardiology and many other areas of cardiology. I'm not going to dwell on his introduction because most of us know him, but just in case you don't realize how highly accomplished Dennis is, he's been with us here at Sunnybrook for 15 years or 16, the time flies, but in that time he's become full professor. He holds a mid-career career scientist award. He's the inaugural holder of the Jack II Chair in Cardiovascular Research. He's received numerous awards. He's published profusely, and he's on multiple editorial boards, including senior editor for Circ Outcomes. So this is our first go at this new format. I don't know if Dennis, you want to talk about some of the ground rules and so on, but I'll just refresh you about Zoom etiquette here. Please leave yourselves muted when you're not speaking. Please use the chat box if you have questions that come up during the presentation, and then we'll be able to address those, and I'll let Dennis decide if he wants to address them on the fly. Please, if you're comfortable doing so, leave yourself on video so we can all see who's here and participating. So I'll hand it over to you, Dennis. I hope I haven't forgotten anything important.
Yeah, thanks a lot, Eric. I really appreciate everybody for coming. We haven't had these rounds for some time, and we really took a lot of thoughts and effort into it. So I'll give some. Let me see if I can advance my slide. Okay, here. So I thought that over the next 45 minutes or so, for those who haven't joined the rounds, we would like to, just give an updates about Schulich, the Schulich program, a little bit of introduction about the Grand Rounds. Then I think that I'm going to spend about half the time talking a little bit about background of cardiovascular outcomes research. Talk a little bit about some recent research that examined gaps of practice as pertain to PCI, and thoughts about current healthcare. I really hope that it's more than a didactic type of representation. People, I would like people to stop me. Just I think having a chat, having a time that we can spend together despite being on Zoom, I think would be fantastic, because we don't get the chance to see each other very much, but now I'll get to it. So Brad hasn't been here, may not be on rounds yet, but I really want to thank him for serving 10 years as the Schulich Heart Program and the head of Division of Cardiology at Sunnybrook. He's a Reitman Chair, he's an interventional cardiologist, and most everybody knows Brad. He's still really interested in medical innovation, disruptive technology in CTOs. And really, I think that, the divisions has been in great shape because of Brad. Thanks, Harinder, for coming. He has been appointed the next chief of the heart program as well as a program head. That happened last year. We have been good friends for more than 10 years. He does health outcomes, health service research with real expertise in decision-making and economic analyses. He's had a new research chair in structural heart disease and policy and outcomes. So, for those who are attending rounds and who haven't been to rounds, if you have any clinically related questions, always email Harindra. He's really 24/7 for sure. So he wakes up early, and anything that he would be willing to help. As Eric mentioned, I had been very fortunate and really happy to be at Sunnybrook. Who was appointed research director of the Schulich Heart Program at Sunnybrook Research Institute, and Kaluva was just here, and also does cardiovascular outcomes health services research really have an focus to improve quality of care and outcomes. And Reno was very fortunate to be named the Track 2 chair, who passed away in 2018. I think we always remember him, and have the opportunity to carry that throughout my career. It's been a great friend and great mentor for me. We've extended invitation to our partners. One of the benefit of Zoom is that rather than having people show up at rounds at 7:30 in the morning at Sunnybrook, and now people can join in. And I know that not everybody can join in at every time, but if something that's interests you, I think that's fantastic. So I think that we're going to have our really many partnering hospitals from Humber River, Mackenzie, Norfolk General, even Health Science North and Michael Garrett Hospital. And I worked there for the first time yesterday, which is fantastic. Also KMH Cardiology and Internal Medicine, they have a big group that does outpatient practice. So these are the many of the physicians, allied health professions that we're sending out invites to, and we really welcome to rounds if you haven't been here before. As Eric had mentioned, we had spent a lot of time rebranding our rounds. In the past it was really focused on research, and now I think that we kind of change it to a tradition of grand rounds to focus more broadly. In the past, we have face-to-face meeting. I think for September to December, we're gonna do Zoom. Given the pandemic, it's still ongoing, and there's different restrictions of gathering. It happens Tuesday, 7:30 to 8:30, and we're gonna have clinical topics, research topics. Stephanie Poon is also gonna lead some quality improvement projects and topics that we're going to discuss, cases and such, and those are always quite interesting. For physicians, these are talks that give 1 hour credit. If you need to claim them, please track your time. It is a bit hard to track these time on Zoom. In the past, we have a sign-up sheet, but just track your time. Email me. We at the end of the year, we usually give out that certificate at the end of the year. So if you just track them November, December, email me. I think we'll kind of get that done. We kind of just will trust you if you were at rounds. Some of the Zoom etiquette that Eric had mentioned already, but I think it's just, for me, it's a time to connect. Just feel free to interrupt. What we also going to have is that we're going to record and post these rounds on a webpage that's being developed. So I think it's going to be coming very soon. So just, don't feel shy. And if you want to put on camera, that's great. If not, that's good. But just kind of interact, I think would be fun. It's no, it's just good to kind of see each other in my perspective. A little bit of a plug, we actually had a lot of remarkable speakers over the next 6 months, from outcomes research, from EP, interventional cardiology. So, please join us next week. My mentor, Helen Krumhaus, is giving Zoom rounds next week, and we're going to have late starts in our cath labs, in our surgery, to kind of listen to the talks. He's just an incredible person, researchers, and he's going to give us a ton of insights into different things. So please join us next week. I think you'll promise to be incredible for the talk. I'm going to stop there. Anybody have any questions so far? I can just take a pause and talk about something else. If not, then I will keep going. So when we talk about cardiovascular outcomes research, it's always been a little bit of a black box. People don't really know what the field does, and we publish a lot, but not necessarily like randomized trial. One of the things I want to talk about is that, well, what do we actually do? This is the architecture of outcomes research, and this is something that Hans Krumholz really was the grandfather of this type of research, and he wrote that in a review paper in JAMA about 10 years ago. And I think that there are different domains. The research that we do tend to be comparative effectiveness with patient effective perspective as well as health system improvement. In terms of comparative effectiveness, the aim is not to replicate randomized trials, but the game is to fill in the gaps to determine what strategies are most effective in large and unstudied populations. So, to give an example about the COVID nowadays, it is incredible that in Canada and Ontario that we don't really have any COVID information on race and ethnicity. So, because those data were not captured. So I think that one thing is that we tend to kind of, many groups get understudied all the time. Women, the older age groups, the socioeconomically disadvantages. So I think that our outcomes research tend to try to fill in those gaps in knowledge. The perspective of the patient. So sometimes that, again, when we think about randomized trial, the outcomes, it's often mortality, and heart outcomes, and often that's not the case that what patient really would be interested. So there was one study that we asked the patient to say, well, what's the most important for you in terms of heart failure? And invariably people said quality of life, and some of those values are not representative equally in clinical trials, and something that we have to keep in mind even in clinical practice, that often that we say, well, this therapy would, improve your outcomes, but that's not necessarily aligned to the patients. And health system improvement is something that, well, what can we do to the healthcare system at large to ensure equity, access, and care? And some of the things that we've done is that, appropriateness of care, whether things are appropriately applied to the population, as well as do everybody in the healthcare system get the same level of care? So, for example, if you live in a different neighborhood, will you get invasive cardiac procedures or not? So those are the things that we continue to kind of examine. If you think about the types of inquiries, you can think about discovery science, application science, and surveillance. So those are kind of the three types of research that we do in terms of methods. I think discovery science, things like determinant health, methods to assess risk. So these are kind of the analytics. I think that you hear a lot of big data analytics now, which is really kind of, started with these outcomes research. Is that, well, could we do modeling to predict somebody's chance of dying, somebody's chance of rehospitalization and such. Applications, there's a really big field on application science now. So how do we develop, use, and evaluate tools and strategies in the real world? So these are kind of implementation sciences, like could we implement the system of care that will benefit a lot more people? So as simple as we just did a study recently that looks at ticagrelor use in Ontario, and you'll be surprised that there are many hospitals that still don't use it at all. That they're using clopidogrel, and the utilization rate is zero. So how do we implement the latest science to kind of help clinical practice in all fields? It's something that it's very important. And finally, surveillance. I think surveillance, these are kind of big data epidemiology, and as you can see in the COVID time, it's all about trends, right? How does how does, how many cases are there in COVID, where they are, and such like that, and, where are the gaps in knowledge. So I think those are the 3 domains in type of inquiries. And at the end, I think the outcomes research really focus on the patients, what is being achieved for patients and what can be done better. And really, we try to provide critical information to improve clinical decision healthcare policies, and apply it to healthcare practice to improve patient outcomes. So those are things that always have the patient in mind is the goal of our research. So this is this is just a cartoon. Good news is that, well, we're able to save the legs, and but it's attached to the body. So one of the things about our healthcare system is that, well, we always think that we're doing great, but sometimes we just don't have the insight that we haven't done. So this is something that we keep in mind. Just going to switch gears a little bit and I'll talk about a couple of projects. Not to just to show that what we have done recently, something that just to springboard in discussion, hopefully. So. For those who might not know, coronary angiography is one of the most common procedure done in developed country. In Ontario alone, each year there's about 70,000 angiogram that's being performed. Obviously, in the US, there are millions of procedure each year. That's even a lot more. The problem with angiography is that it is a X-ray that is in 2-dimensional structures, and the coronary artery is a 3D structure. So as depicted at this cartoon, so this is the artery like a donut. So if you have a narrow lesion that is projected this way, so that donut with a hole that's kind of vertical, so you can see that the angiogram picture looks like this. It's not really that blocked. So this may be 25% stenosis, represented here. If you kind of project the vessel in, let's say, just tilt the donut kind of upside down, you see that, actually it is a lot more blocked than it's supposed to be. So, the angiography now looks at about 75% stenosis. So this is the problem about coronary angiography. It's a 3-dimensional structure projected in a 2-dimensional view. So there's inherent problems with angiography. And it's been studied over and over again that when you compare coronary angiography with quantitative assessment, so this study, and I just picked this study that I remember recently, that they compare the mean difference in diameter stenosis in lesions without myocardial infarction, and look at visual assessment versus QCA, which is a quantitative assessment in about 1,300 patients. And you can see that if you visually, you always kind of tend to overcall. And this is kind of a line to say, well, it is the same here, but if you kind of use visual assessment, that it's always tend to overcall the lesion. And so there's large discrepancy in general between these two assessments. And one can think about different reasons. So many of those would argue, well, interventions like to fix stuff, and everything is called very severe, and that tends to be one of the most common reasons. The intervention would say, well, I took different views, and some views are worse than others. So that's one of the inherent problem of angiography. Plus, there's some different incentives that's inherent to the procedure as well. So there are new technology that's available, and as I say new, it's not really new. It's been developed for more than 10 years at least, and it's called fractional flow reserve. And this is basically having a procedure that measure the pressure sensor of the distal vessel versus the so distal coronary pressure versus over proximal coronary pressure during maximal hyperemia. And since that time, there's different variation of this, but basically how I explain to patients is that, well, if you think about the coronary arteries, like, the pipes in the kitchen sink, even if you have blockage, you might not fix it unless it kind of reduces the flow, right? So this is flow that turn into pressure. So if the pressure are not equal before and after a blockage, you don't need to fix it. If you start having degradation of pressure, meaning that the flow is also not that great, and then that's more a reason to fix the coronary vessel. So this is really the simple concept of fractional flow reserve. There are landmark studies that looks at comparison of the use of pressure wire or FFR versus no FFR guided intervention. So this trial is probably one of the most well-known trials, FAME1 and FAME2. This is FAME2 that looks at patient with stable coronary artery disease. You need to start having a visual assessment. So they kind of include everybody who has an assessment of more than 80%. And the number that they use is 0.8. So 80% is the value. In the past, the number is used as 0.75. So right now we use the number of 0.8 as normal versus abnormal, less being more abnormal. If it's more than 0.8, then it's okay. In this study, it was just stable coronary artery disease patients, so no myocardial infarction, no STEMI, no left main, no prior bypass surgery. They had two groups. One is just medical therapy versus FFR guided PCI, and the primary outcomes were death, myocardial infarction, urgent revascularization, and such. And so what they found was that, if you look at the outcomes, the overall composite outcome was in favor of interventions, the hazard ratio of 0.86. But in general, it is driven not by death, but mainly by urgent revascularization. So they define it as, having mainly repeat PCI that require hospitalization. So, as you can see, there's really significant difference between the two groups. The myocardial infarction, the curve may separate after a few years, but it's borderline significance. But I think that most people would accept that FFR guided therapy would reduce urgent revascularization. That's kind of probably the most solid evidence from FAME trial. FFR. These modalities are accepted by guidelines. So if you look at the AHA-CC guidelines, less than 0.8 is acceptable as having downstream ischemia. Similarly in the European guidelines, that it's accepted as having a positive stress test. Kind of wanted to talk about this study that we did. Manish, who is one of our new clinical associate doing a PhD, has led this project, and many others have been involved in this. So we were looking at this study that used real-world data looking at fractional flow reserve and patient with coronary artery disease in Ontario. So there are two things. We were not planning to replicate the FAME trial, but the one thing that we were interested is that, well, interventionists like to do interventions. Well, if their FFR that they did, would they still follow the thresholds in clinical practice? One could guess that, well, they don't. Sometimes they kind of say, well, the lesion is tight. I'm going to fix it anyways. So we were interested to see, well, what happens in clinical practice. And number two is that if these numbers were followed, would that be associated with improved outcomes? So those are the two main objectives. But in real world, there are two groups. One is the ischemic group, less than 0.8 FFR, which is similar to the FAME trial. The other one would be the non-ischemic. So if you have a non-ischemic FFR, if you end up getting a PCI, would you be okay or would do worse? I think, one of our prior hypothesis is that, well, PCI is pretty safe. It's probably nothing really happen. I think this is one of the, for the trainees, this is one of the remarkable things we can do projects in Ontario, is that, everything is captured in a single healthcare system. We can follow people in OHIP and, we can look a lot of information. So, during this time from 2013, 2018, we saw that almost 500,000 patients who had coronary artery disease and, coming for an angiogram. So obviously we had to exclude people. Right now the FFR is not performed in, all the cases. It's actually just the minority cases. So we have to exclude people who didn't have FFR, people at STEMI, multivessel PCI, previous bypass, kind of trying to create a cohort that's a little bit similar to FFR, to FAME, but we also include people with non-STEMI. There's some evidence to show that they're beneficial. And created two cohorts. Sorry. The one cohort is that people with ischemic FFR, there's about 2,600 patients, and there's a non-ischemic cohort that's about 6,400 patients, and we use the same similar outcomes. We have mortality, hospitalization, revascularization, and so on. So I'm going to start with the people with the ischemic FFR, and that's the simpler cohort because that's been studied. So when we look at people who had ischemic FFR, one of the things that's interesting is that only 3/4 of the patient had PCI and about a quarter that didn't. And that was a bit surprising to us because, well, we think about you did a procedure, you've got a coronary wire already, like why, like what was the reason that the lesion wasn't fixed, right? We didn't study the reason, but we compare the outcome. So when we look at the two cohorts, we saw that the mean age is around 65%, about a quarter of them were female, and diabetes was about 40%, on the study cohort. The majority of the time they have an OED lesion. And interestingly, there was substantial benefit of clinical outcomes if you had a PCI. So these are Kaplan-Meikers of patient who had PCI versus no PCI. And if you look at about 5-year incidence of MACE outcomes, if you had PCI, it was like 31%. If you don't have any PCI, it's about 39%. And so this is associated with significant reduction of hazard ratio, and everything kind of falls in the same line, although the individual outcomes were not significant if you combine them. So it's pretty consistent with clinical trials. If you have an ischemic cohort, if you had revascularization, you do better. So I think that is pretty similar message. Then we switch gears a little bit to the other cohort. So again, these are patients that undergo this FFR procedure. The physician found a value that is more than 0.8, that is non-ischemic. About 13% still got an intervention, and we can think about the reasons, right? Number one is the lesion looks kind of tight. I may not necessarily trust the FFR. Maybe patients have a lot of symptoms. I'm going to try to fix it anyways. So I think there are a lot of reasons that why the physician chose to kind of do PCI in some of these cases. I think 10%, it's probably quite a reasonable number, 13%. And we did the same thing. We lined them up into PCI versus non-PCI. And again, the cohorts are quite similar. You have mean age around 65, 66. Diabetes is about 35% or so. interestingly, we saw that the Kaplan-Meier curve was reversed. So rather than having PCI having better outcomes, the no PCI group actually had better outcomes in this study. Actually, there was, if you look at mortality, that didn't show any difference, but you have myocardial infarction and stable angina revascularization. So I think this was actually quite insightful for us, despite we feel that, well, putting in the stent isn't really going to cause any problems. It actually does. And I think the unstable angina is the most convincing. We see a lot of patients that, after stent, they have chest pain, they come back to the hospital. So they go to the ER because of more chest pain, right? So like they have a lot of symptoms. So I think it's something that we have to keep in mind that PCI isn't benign if the indication is not correct. You also get more repeat revascularization, and that's pretty consistent. So I think in summary of that project, I think number one is that if you do a non-adherence of PCI procedures according to FFR was observed with both. We saw underutilization as well as overutilization. The underutilization, interestingly, in ischemic patients tend to be was more often than overutilization. If you do PCI in ischemic patient, they have better outcomes. Conversely, there's increased risk of adverse outcomes for PCI for non-ischemic patients. So this is something that to keep in mind for interventions for sure. This is something hopefully that would be something that's in the past. Many of us worked in the 10 for a shift or two during COVID, and hopefully the 10 is now gone. Hopefully that we won't see that again. I saw, sorry, I'm going to just answer the chat room. Harinder, do you want to just maybe say what you say to everybody about your question?
Well, I'm being a little bit controversial, and I've had the advantage of seeing these results before, but they're kind of fascinating because you are looking at a subset of patients in whom we decided to do FFR, and you can argue that this objective test, the results that you have show that when a physician in those few instances decides, well, I've decided to do this test, but I'm going to ignore it, and I'm going to use my judgment that on average, that appears to be a mistake, that it's associated with worse outcomes when going against what the evidence would suggest. So that's kind of interesting in and of itself. But you are only looking at a relatively small proportion of patients who actually had FFR. So we did a study on this a few years ago, and I suspect the rates have increased a bit, but it's about 5% of PCIs that have FFR in this province. So the overwhelming minority. And so your thoughts on the implications of that? Like, there are many who argue that prior to doing PCI, because of the limitations of kind of visual assessment of an angiogram, we should be using these objective tests more.
Yeah, and I totally agree with you. I think that as interventions, we see a lot of stress tests in the that are potentially false positive. That I don't know whether that is strong enough reason to call that ischemia. So I think if you think about the guidelines, PCI should be performed in people with symptoms with ischemic burden and such for stable coronary artery disease patient. But increasingly, if you do more FFR, I think that some of the studies have shown that your outcomes in the lab have improved. You don't need to use as many stents, and people are not subjected to long-term dual antiplatelet therapy. So I think that it is something that is objective if you do it to show that it will be better. And we also learned that, for those who, we do, I think, quite a bit of FFR, we also see that many of the lesion, although it looks tight angiographically, they're not really significant. I think that I do think that increasing use of FFR will improve your outcomes, as a interventional cardiologist as well as in the cath lab. I think the really big question is that it's an incentive, right? From and you, Sam, Amina can speak to that a lot more. It is not reimbursed. We have to find the funding to do FFR. So I kind of call these misalignment of the incentives, like and funding. They would fund a stent, but they might not fund the PCI, and they would fund a stent, but not an FFR, and makes it kind of disincentive to do them. So I think. But I have no doubt that if you use more of it, I think that it is definitely better. Graham, do you want to say a question?
Sure. I guess it's just a comment and a question. I mean, this is an outcome study, not a randomized trial. So I mean, your language sort of implies that in the non-ischemic group, PCI caused these events, but we can't conclude that. Perhaps those clinicians who decided on PCI saw something else that indicated higher risk. So, maybe you just didn't capture the right measures in terms of why they decided to do PCI on that non-ischemic group. I mean, it suggests that maybe there should be a randomized trial here, but I guess I really want to emphasize this is correlation, not causation.
Yeah, I think that is fair. I think I use kind of more confirmative language when I present, but I think during the study, I think we're careful to do so. And I think that there are always potential unadjusted confounding during an observational studies. But I think that there is, I think right now there's more evidence to show that, like if you think about courage ischemia, there are more studies to show that if you don't have symptoms, PCI has never really been beneficial. And so, a lot of times, we see lesions that patient doesn't have any symptoms. I think if they're not ischemic, I think there's very little evidence to show that the patient would benefit from it. So I think the overwhelming evidence now is that, well, the patient has to have some reason for you to put in a stent. And I think that, having a non-ischemic FFR, regardless of the risk of the patient, has not been demonstrated to benefit the patient. So I think that's probably would be my message. Like it's pretty hard to put in a stent when you have an FFR that's like 0.85. I don't think anybody would defend you. But thanks for that comment. So I'm going to switch gears to say that we don't, in the healthcare system in Ontario and Canada, our bed capacity is very low as compared, to the US. I've worked in the US before. Beds are not an issue. You never have to think about bed capacity, but in our system, it's quite different. So in the next 10 minutes, I think I'm going to just talk about talk about a study that's led by Mina Madden. And we really enjoyed, I really enjoyed working on that with her. So, I think PCI is one of the most common performed procedure as well. There are about 25,000 procedures each year in Ontario. In the US, it's about 1 million procedure each year. Discharging people after PCI has the potential to improve hospital capacity. It's something that we have done. But the two sides of the story. So like the people who discharge people like Sunnybrook would say, well, it's cheaper. They don't have to stay in a hospital and patients really love it. Patients don't have to stay overnight. On the other hand, some would say that, well, during that time that the patient stayed over, we didn't have an opportunity to talk to patient about risk management. We didn't have a chance to kind of give them all the prescriptions, and maybe they don't really want to go home because they live quite far. So I think there's always been a struggle about the benefits of harm of sending people home the same day after PCI. And this is a study that we've done a couple of years ago, and really to look at, to evaluate the hospital practice of same-day discharge elective PCI in Ontario. And number two is that we wanted to evaluate the safety because there's always a concern that whether people could do worse after early discharge. Using a similar database, we looked at all the PCI done in 2008 to 2016 with various exclusion. And at the end, we had two cohorts or two groups. We gathered about 10,000 people who were discharged the same day and about 25,000 people who were discharged overnight. And we had outcomes of all-cause mortality, hospital readmission due to ACS within 30 days. We chose a very short outcome because this should really impact really early on and not for a long time. And as you can see over and over again, the PCI patients in Ontario are pretty similar. They're around 65. They're mostly men. 30 to 40% of diabetics. This has less exclusion, so we also include people with PCI and bypass previously. And I think this is the most interesting slide to me. There were, I think, maybe 17 PCI centers in Ontario at that time, and these represent the rate of discharge at that time. And we had to suppress the hospital names because of potentially stigmatization, things like that. So we don't look at the hospital name, but you have hospitals that are discharging people 80 to 90%, and there are like a lot of hospitals that are discharging less than 10% and like 5 that are discharging nothing, right? So the mean discharge rate was actually only 30%, but there's such variation of the practice across the province. And, we have a regionalized system that, people are, everybody is trained the same way, in Canada. So it's kind of interesting that, there's such large variation in just this simple practice. And if we look at the outcomes, and, the intention here is not to show that same-day discharge is better. And we're really looking at whether same-day discharge is worse. Because that, one would really think that, well, if you kind of can discharge the same day, you're usually healthier. We took the effort, it's Graham's point is that, the confounding, we took the effort of trying to balance the cohorts out. So we took patients that, if they stay 2 days, those are excluded because they have no represent complications. We took people, if they're from a nursing home and, from different, like if they have a lot of different comorbidities, we kind of got rid of them. So we really want to take a cohort that, those are your typical PCI patients. And when you can see that, the outcomes rate are very low. I think this is the reason now that, most people are pretty comfortable doing that. And obviously we are not the rest of the Ontario. So, if you look at mortality rate is 0.1% at 30 days. If you look at, death, AR, MI or unstable hospitalization is about 1.3%, 1.6%, but everything kind of lined up to say that same day discharge is not associated with worse outcomes. So I think in summary of this study is that same day discharge PCI is safe and not associated with adverse outcomes. So this is a back of the napkin calculation. So, we said that, well, if we go from 30% and let's say it's to 80% in Ontario who can discharge patient after elective PCI, the hospital can save, 35,000 hospital stay beds. Something like that, could be impactful, right? And I showed a tent is that, we are we just don't have enough beds. So like this, as simple as that, you know, can save some hospital bed. You know, we got a call from an Auditor General and things like that. So I think that we'll see what happens, and you'll be interested to also see that you know, whether practices change. So I'm coming to my final slides. You know, I think that we can, you know, if people are interested, we can kind of have some discussion about the healthcare. But I would say in general, it is pretty difficult to apply new healthcare practices to improve care in general. You know, I think we have been in the business of improving cardiovascular care, and we obviously have had a lot of successes. You know, things like use of beta blocker, dalterbulin, it's really initiated by the group. You know, I think if I were to think about Canada versus US, we have less of a quality improvement mandate or culture. You know, there in the US, there's been a lot of, you know, whether it stems from these US new reports, you know, ranking and things like that, they've always had more competitive type of way to structure healthcare, and part of the quality mandate is, you know, part of the necessary way to kind of gain points in those in the rankings. So every hospital have them. There's some misalignment of incentives. I think in the healthcare system, we tend to reward quantity and not necessarily quality. And obviously, there are many priorities of healthcare. You know, not even COVID. You know, before COVID, you know, sometimes like 20 years ago, I think 10, 20 years ago, cardiovascular care was the main priority. Then comes cancer and things like that. So there, you know, obviously there are many priorities of healthcare, and we sometimes if you are in a disease condition that doesn't get priority, and it makes it a lot more difficult. So I want to thank everybody for coming to our first revised grand rounds of the Schulich. I have that because I was half making a slide when I was watching the Jays games. I kind of thought that I'll use the Blue Jays slide to end. So thank you very much, and hope that we can have some discussion. Email me if you have any comments, any ways you want to improve them or change them. If you want to present, just also email me. So thanks a lot.